Good morning, ladies and gentlemen. I'm very glad this morning to have one of our distinguished physician, Dr. Waleed Hamza. He's an assistant professor of medicine at the University of Kordofan, and he's a senior specialist in Al Teaching Hospital and Orsit Hospital, Mogadishu, Somalia. Waleed is an active member in the Society of Hypertension, and he's a member of Sudanese Society of Hypertension and a member of International Society of Hypertension. Today, we are going to talk about very important topic in the field, which is very important for the frontline health service providers, golden practical tips in the management of hypertensive emergency. Dr. Waleed, I'm very happy to have you here. Please welcome, and the platform is yours.
اوكي ثانك يو فيري ماتش دكتور الدسوقي. وفي البدء بعد التحية والسلام اسمحوا لي يا اساتذتي الاجلاء، زملاء الكرام وجميع الساده الحضور، ان اهنئ الاخ العزيز دكتور الدسوقي حسن بمناسبه ترفيعه الى درجه الاستاذ المشارك من جامعه كردفان، مع تمنياتنا له بمزيد من العطاء والانجاز بتمام الصحه والعافيه ان شاء الله. This morning, really, I am very happy and so glad, and it is of my great pleasure to be hosted in this virtual clinical meeting to talk about and to touch one of the most important locally and global health issue, the hypertension, and in particular, the hypertensive emergency, which is a major cause of cardiovascular complication and premature death worldwide. Our goals for this talk will be a background and exploration of the magnitude of the problem locally and worldwide, definitions and terminologies, focus history and examination, test and workup of the case of hypertensive emergency, common example of hypertensive emergencies and their pharmacological treatment and intervention. Hypertension or raised blood pressure, as we know, it is one of the major contributors to the global burden of disease. And worldwide, the prevalence of hypertension is increasing since 1990. And it is estimated that about 1.4 billion of adult peoples have hypertension by the year 2024. This compared to 650 million in 1990. And actually, in Africa and the low to middle income countries, this reports the highest prevalence of hypertension, with about 80% of deaths from cardiovascular complication. Regarding our situation in Sudan, it starts to be more clear this burden of the disease and the problem since the conducting this program of the screening, the measurement months, which is worldwide screening program for hypertension. It is conducted by International Society of Hypertension, and in Sudan it is conducted by this Sudanese Society of Hypertension, which is under cover of this International Society of Hypertension. And actually, the report reflects that Sudan, it witnessed the highest second prevalence in North Africa. So screening and early management is essential to prevent and to stop this silent killer to avoid the complication and premature death. Let us see some important definitions and terminologies, and this is very important in diagnosis of our case and definition of the case. Hypertensive emergency, it is one of the hypertensive and it is one of the top medical emergency, and it has certain criteria. By definition, when we tell this patient is hypertensive emergency, that is means it is severe hypertension with systolic blood pressure is equal to or more than 180 millimeter mercury, and or diastolic blood pressure is equal to or greater than 110 millimeter mercury, with evidence of new or worsening target organ damage. And this is very important for the definition. Other differential diagnosis, we have some cases with very high blood pressure, but there is no evidence of end organ damage. And in such a case, we find that the blood pressure may be it will be more than or greater than 180 over 110, but there is no evidence of end organ damage. And in this case, we classify the case as asymptomatic markedly elevated blood pressure. And this is previously known as hypertensive urgency. So this is the difference, is the only presence or absence of the end organ damage. Again, another term is hypertensive crisis, and this is its general term. Usually in this case, blood pressure, it is more than 180 over 110. It could be associated with end organ damage, and in this case, it will be hypertensive emergency. And maybe there is no evidence of end organ damage, and here we classify it as asymptomatic markedly elevated blood pressure. So hypertensive crisis, it could be hypertensive emergency, or it could be just asymptomatic markedly elevated blood pressure. Another term, malignant hypertension and accelerated hypertension. And many people, they use these terms without know the clear difference, but there is difference between malignant hypertension and accelerated hypertension. Anybody knows the difference between malignant hypertension and accelerated hypertension? Of the floor. Welcome. ارفع صوتك شوية. Welcome. Welcome. So the malignant hypertension and accelerated hypertension.
دكتور وليد لو سمحت لي،
Welcome,
أستاذنا
Dr.
بروفيسور أحمد عجب الدور معانا هنا. هو كان in the medical school، يعني لما كنا سنة رابعة he will say it, malignant hypertension is a hypertension with fibrinoid necrosis. فأنا I don't know this concept is change or still is there, Professor. Okay, Walid, welcome.
Thank you for Professor Abdullah Ajabador, Ahmad Abdullah Ajabador, and we are very happy to having you in this session. وكما عودتنا يعني حضور وألق في كل الميتينجز. نحن البروف ده عايزين نحلقه يا بوس. Let us continue. The difference between malignant hypertension and accelerated hypertension, actually, it is lying in the underlying pathology. Both of them, they are classified as hypertensive emergency with blood pressure more than 180 over 110 with evidence of end organ damage. But in case of malignant hypertension, this is usually characterized clinically by presence of papilledema. This is very important. uh, plus other feature of end organ damage. And this it is picture of fundoscopy in patient with malignant hypertension. It show clear papilledema with raised and swollen optic disc with phlegm, hemorrhage, and exudate. Whereas the case of accelerated hypertension, in accelerated hypertension, this is defined as recent acute significant increase in the blood pressure over the baseline, and it is associated with end organ damage, such as flame-shaped hemorrhage, tissue exudate, but usually there is no evidence of papilledema. دي نخلي في نهاية السيشن إن شاء الله البروف يتكلم لنا عنها أكتر إن شاء الله. Let us now approach our case with history and examination. Focus history and examination, it is very important in case of hypertensive emergency. And you have to ask specifically to search for any feature of end organ dysfunction from absence of these symptoms. Ask specifically about any history of chest pain, shortness of breath, palpitation, lower limb swelling, change in urine volume and color, headache, blurred vision, convulsions, disturbed conscious level or speech problem, and history of weakness. And also try to pick up any circumstances that surrounding the hypertension, and try to pick up any identifiable etiology so as to work up and control. In examination of patient presented with suspected hypertensive emergency or high blood pressure, first step, usually try to take a proper blood pressure measurement, and this is very important because this is the cornerstone in the diagnosis and classification of the case. To take a proper blood pressure measurement or reading, patient should be seated in standard position with his back supported to the chair. The foot should be against the ground, flat against the ground, and the forearm should be supported. On table, and it is preferred to be at the level of the heart. And try usually to take 2 readings bilateral, especially in the case of high blood pressure or hypertensive emergency, because sometimes you may get some difference, and this may reflect serious underlying problem like aortic dissection or coarctation of the aorta. This standard in the measurement of the blood pressure, it is very important, and it is classified as class 1B. That is means it is with general agreement, and it is highly recommended and indicated with level of the evidence is B. We have some special cases with high blood pressure associated with atrial fibrillation, and in such a case, it is better to avoid use of oscillometric monitors because this is affected by the abnormal heartbeat, and in very common, it gives inaccurate reading and inaccurate assessment. In such a case, it is recommended that to use manual auscultatory method and to take multiple readings. And it is class 2A with level of evidence C. Class 2A, that is means there is conflicting evidence, but in class 2A, it should be considered anyway. And try always to conduct complete cardiopulmonary and neurological assessment because, as we know, the most common complication of hypertension are cardiovascular and neurological complication. Important test for workup of our case. We have routine test should be done for everyone. and we have other tests which are optional. And actually, all of these depend on the finding from history and examination, and then you work up your case accordingly. We have to do, of course, renal function test to assess the blood urea and creatinine, looking for any evidence of renal damage. We have to calculate the estimated GFR. Electrolytes are very important, especially sodium and potassium. Urine analysis to look for any feature of proteinuria, hematuria as evidence of renal damage. Fasting blood glucose should be screened for any patient with high blood pressure to look for any comorbidity because diabetes is common coexistent comorbidity. TSH to screen for any thyroid disturbance. Serum lipids include all total cholesterol, LDL, HDL, and triglyceride, as well as CBC. And here we interested mainly in hemoglobin and hematocrit. ECG, it is of top important because it show many problems. We're looking for any complication of hypertension at the level of the heart, like feature of ventricular strain, any feature of arrhythmias, especially atrial fibrillation, and other complication like feature of ischemia and acute coronary syndrome. Cardiac biomarkers, this is if the case is suspected as acute coronary syndrome, especially cardiac troponin. Chest X-ray, it needed to look for any feature of pulmonary congestion and pulmonary edema. Echocardiography to look for complication of hypertension such as ventricular hypertrophy, regional wall abnormality in case of ischemia, and others, and to estimate also the ejection fraction in suspected case of heart failure. Urgent CT brain, especially in case of neurological emergency, to exclude brain hemorrhage. Fundoscopy is important to look for any feature of hypertensive retinopathy. Transesophageal echo and aortic CT angiography. This is recommended for patients presented with features that suggesting aortic dissection. Other investigation we can do according to the medical history and according to the underlying features, symptoms, to look for any feature of secondary hypertension. And the most common cause in this is the primary hyperaldosteronism. So we have to do aldosterone to renin ratio, 24-hour urinary cortisol in case of suspected Cushing syndrome or Cushing disease, 24 urine or plasma metanephrine and normetanephrine, and this is important in case of suspected pheochromocytoma or paraganglioma. In addition to abdominal ultrasound, renal Doppler ultrasound, and abdominal CT angiogram in case of renovascular hypertension. Example of common hypertensive emergency include cerebral infarction, and as we said, neurological emergency, it is one of the common presentation. In addition to subarachnoid hemorrhage, intracranial hemorrhage or intracerebral hemorrhage, cardiovascular complication like acute heart failure as complication of mainly left ventricular dysfunction, pulmonary edema, hypertensive encephalopathy, ischemia, and acute myocardial infarction, aortic dissection, in addition to retinal and renal complication. And if female, we have to exclude preeclampsia and eclampsia, especially if she is pregnant. Let us now to talk about management of our case after the confirmation of hypertensive emergency. First of all, the first step in management of hypertensive emergency case after you confirm the case and classified your case, you have to admit the patient to the proper area for standard follow-up. And this is usually either ICU, CCU, if there is feature of cardiovascular emergency like acute coronary syndrome or aortic dissection, or HDU This is a standard area for admission. And try to start immediate intravenous antihypertensive medication with gentle reduction in the blood pressure and close monitoring and follow-up. Always we recommend that our aim should be to be a gentle reduction in the blood pressure because we need no harm. As we know that the reduction in the blood pressure هو سلاح ذو حدين. We have to take care about the benefit from the reduction of the blood pressure in such a case and the complication of sudden drop in the blood pressure that may end with catastrophic complication due to tissue hypoperfusion and ischemia. This step, when you decide to select your medication, definitely there is a large list of intravenous antihypertensive medication, such as intravenous labetalol, hydralazine, calcium channel blocker, such as nicardipine, and others. To select which of which it is not a matter of luck and it is not guessing. This is actually depend on the underlying complication and depend on the nature of the hypertensive emergency patient presented with. This is very important because sometimes you try to reduce the blood pressure by using some of these intravenous antihypertensive and you make the situation it is more worse rather than you treat the patient. And this may end with death. In case of acute ischemic stroke, one of our common neurological emergency, here we prefer is that the medication of choice to use intravenous labetalol or calcium channel blocker nicardipine plus ismolol. And this is indicated only in patients with ischemic stroke to reduce the blood pressure with this intravenous antihypertensive with certain indication. One of them, if the blood pressure from the start is very high, more than systolic blood pressure more than 220, with diastolic more than 120, or patient has associated other hypertensive emergency like aortic dissection, acute coronary syndrome, and so on. Although you are allowed to reduce the blood pressure if your patient is candidate and eligible for thrombolytic therapy, and he is presented early within the golden hour. This is the first 4.5 hour, and you need to start thrombolytic therapy for this stroke. Here, you are allowed to reduce the blood pressure, and our targeting here to reach systolic blood pressure of less than 185 with diastolic of less than 110, so as to start thrombolytic therapy. In case of acute cerebral hemorrhage, is again another neurological hypertensive emergency. The preferred medication of choice again include beta blocker labetalol, calcium channel blocker nicardipine, and ismolol. And it is very important in such a case to avoid this class of vasodilator, especially sodium nitroprusside and hydralazine. Because as we know, the cerebral perfusion pressure, this is very important for the cerebral perfusion. It depends on two factors. It depends on the map and depends on intracranial pressure. So any factors that affecting the map, reducing the map, and increasing the intracranial pressure, this is will decrease the cerebral perfusion pressure, and it may end with hypoperfusion and brain ischemia on the top of this hemorrhage. And this is exactly what this sodium nitroprusside did, because it is potent, systemic, and cerebral vasodilator. It will increase the intracranial pressure and it decrease the map, so it reduce the cerebral perfusion and may induce ischemia. Again, hydralazine, it is also very difficult to be titrated and it has long duration of action, it can cause the same problem. So it is not preferred in patients with neurological emergency, especially brain hemorrhage. If our patient has sign of increased intracranial pressure, here our goal to maintain the map just below 30 and to reduce the systolic blood pressure just below L180 during the first 24 hours. يعني هنا ما بنلعب مع العيان ضاغط، ما تحاول تعمل very aggressive reduction in the blood pressure because you need to maintain the map so as to overcome this increase in intracranial pressure to ensure good cerebral perfusion. But if the patient has no sign of increased intracranial pressure, in this case, we can reduce the map down to the less than 110 with systolic blood pressure down to less than 160, no problem, within the first 24 hours, and after that you decrease the blood pressure gradually. In case of subarachnoid hemorrhage, again, the preferred medication of choice is calcium channel blocker, beta blocker labetalol, or esmolol. This vasodilator should be avoided, as we mentioned before. Our targeting systolic blood pressure here to decrease the systolic blood pressure to 160 millimeter mercury until the aneurysm has been treated or cerebral vasospasm. Okay. The drug which is used very common by people in the emergency department is nimodipine. And this nimodipine actually is used in case of subarachnoid hemorrhage, not as antihypertensive medication per se. Instead it is benefit as vasodilator so as to counteract the vasospasm and to maintain the cerebral perfusion so as to prevent the delayed ischemic neurological deficit. Of course, surgical consultation, especially neurosurgery consultation, is important for some cases that may need surgical intervention. Another neurological emergency is hypertensive encephalopathy. It is not uncommon. And the guideline in treatment for hypertensive encephalopathy, they recommend to reduce the MAP by 25% from the baseline over 8 hours. The drug of choice in this case, again, beta blocker labetalol and calcium channel blocker, such as nicardipine. Let us now to talk a little bit about cardiovascular emergency, and this is very important as well because it is very common cause of premature death. One of the top emergency, medical and surgical emergency is aortic dissection. And here patient usually presented with very high blood pressure with difference between 2 hours, associated with tearing chest pains that radiated to the back in between the scapula. This is a common scenario. Plus minus feature of aortic dissection or cardiac tamponade. In aortic dissection, the preferred medication of choice, of course, it is beta blocker labetalol. Although we can use calcium channel blocker such as nicardipine or sodium nitroprusside. But the issue here is that if you want to use this vasodilator, sodium nitroprusside, in such a case with aortic dissection, you have to use only after good and adequate beta blockage. Because as we mentioned, this drug, it is very potent vasodilator. It can cause and induce reflex tachycardia, and this will make more tension against the aortic wall and it worsens the problem of dissection. Morphine sulfate, of course, it is helpful to relieve pain and to relieve the stress as well. Our goal in such a case, we need to reduce the systolic blood pressure aggressively to less than 120 millimeter mercury within very short time, 20 minutes. And the definitive management at the end, of course, it is surgical intervention in case of Stanford classification type A. This is the ascending aortic dissection. This is important note. As anyone know, beta blocker is the drug of choice. This labetalol by name is the drug of choice in case of aortic dissection. But there is some precaution you have to take care. This beta blocker, if the case of aortic dissection is associated with aortic regurgitation or cardiac tamponade, it will be very dangerous. You have to take care, and this is explained by this explanation. Because in case of aortic dissection that associated with in case of aortic regurgitation that complicated aortic dissection, already you have problem of backflow of the blood during the diastole. And when you use this beta blocker, it acts as negative chronotropic and it decreasing the heart rate. So this will give more time for the period of diastole, and that is means more regurgitation and backflow of the blood. In case of cardiac tamponade, this is another complication of the aortic dissection. Those people already they are suffering from problem in the contractility. So they have decreased stroke volume and decreased cardiac output. And when we use this beta blocker, it have a double action of negative chronotropic and negative inotropic effect. So it decreases the heart rate, decreases the contractility, and it decreases the cardiac output more and more. Another cardiovascular emergency, acute coronary syndrome. In this case, patient presented usually with typical chest pain or sometimes suspected chest pain plus other features. The treatment of hypertension here is indicated only if the systolic blood pressure is greater than 160 and diastolic is greater than 100. And this is very important because those people with acute coronary syndrome and myocardial infarction, they are fragile people. And usually when you are starting the treatment or after a while of this complication of MI, the blood pressure is coming down spontaneously, and we are afraid from low blood pressure rather than high blood pressure in such a case. So if the blood pressure in patient with acute coronary syndrome from the start, it is not greater than 160 over 100, don't touch. Beta blockers again can be used as one of the option, and with nitroglycerin is the drug of choice in such a case of hypertensive emergency with acute coronary syndrome. If you want to use beta blocker, of course, you need to exclude any complication of bradycardia or inferior MI and heart block. Our goal here to reduce the blood pressure by 20 up to 30% from the baseline. In case you need to start thrombolytic agents, such as in case of non-STEMI or true posterior MI, your goal here to reduce the blood pressure to less than 185 over 100, so as to start thrombolytic agent. Very important note, you have to avoid concomitant use of phosphodiesterase inhibitor, such as sildenafil in such a case. Because those patients they are using nitrate in very common situation, and if we use this phosphodiesterase inhibitor in patient who taking this nitrate, this will induce profound hypotension and induce hypoperfusion and aggravate the myocardial ischemia. Another cardiovascular emergency is acute heart failure, and as we mentioned, this is as complication usually of left ventricular dysfunction. In this case, the preferred antihypertensive medication is IV nitroglycerin and calcium and ACE inhibitor enalaprilat, which is active metabolite of enalapril. We add diuretics in case of patient is overloaded, and our targeting here systolic blood pressure less than 130 and diastolic less than 80. Uh, one of hypertensive emergency. This is two problem: cocaine toxicity and pheochromocytoma crisis. Uh, these two emergency, they have similar presentation and they have similar way of treatment in the guidelines. Usually, you are preferred in such a case with cocaine toxicity or pheochromocytoma crisis. And as you know, the pheochromocytoma, it is one of the neuroendocrine tumors that arise from the adrenal medulla of the adrenal gland. It is close differential diagnosis is paraganglioma. Both of them, they are secreting norepinephrine and epinephrine, but in case of paraganglioma, it secretes mainly noradrenaline. And the difference in the site, pheochromocytoma from the adrenal medulla, and this paraganglioma, as it is named, it is outside the adrenal medulla, usually from parasympathetic or sympathetic ganglia. The presentation is similar, but there is difference in the hormone secretion. This area also, our Prof. Ajabador, he can give us more explanation, inshallah. The targeted guidelines treatment here, in case of pheochromocytoma crisis, we have to use alpha blocker such as phentolamine, and this should be used first before to use beta blocker to reduce the blood pressure. Because if we use beta blocker in such a case, as you know, beta blocker will block the beta 2 receptor, which is important for vasodilation. And this will leave the alpha receptor to act unopposed due to this excess of noradrenaline and adrenaline. And this may end with catastrophic severe vasoconstriction and hypertensive crisis. That is why in such a case we have to block the alpha receptor first, and after that, if you need to add beta blocker, you can add. In addition, we have to use also the diazepam to alleviate the symptom of anxiety and sympathetic symptoms. And our target in such a case, it is to decrease the systolic blood pressure to less than 140 during the first hour of presentation. So this is our end of the talk, and thank you very much.
Thank you very much, Dr. Waleed, for this elegant talk, and I think this is very amazing. As usual, Dr. Waleed is very distinguished and very active person in the hypertension era, and I think his talk is more than excellent. Now the floor is open for discussion, questions, comments. Please welcome. If you have any questions to Dr. Waleed, he's ready. If you want to add anything concerning hypertension and hypertension management, this will be very nice. Please welcome. This is your chance for all of your questions to be asked, particularly those who are lying in the front line service to provide services to the emergency cases. This is your chance, I think. Please welcome. And I think the management of the blood pressure in the setting of acute ischemic stroke, it goes for period of time. For years, the guidelines are conflicting. Some people advise to lower the blood pressure. Some of them advise not to lower the blood pressure. Till 2015, 2015, we have a guideline set by the Canadian guidelines, they stated clearly blood pressure equal to more than 220 over 120 can be reduced. But at that time, still the Europeans and the American guidelines, they didn't set up a number of the systolic or diastolic blood pressure to be reduced. Because the concept at that time, people think of in the acute ischemic stroke, the cerebral perfusion pressure is reduced because of, by a way of another, there is some sort of increase in intracranial pressure. So to maintain the cerebral perfusion pressure, the body adapt by increasing the blood pressure to increase the MAP. Because as we know that CPP equal MAP minus ICP. Cerebral perfusion pressure equal mean arterial pressure minus intracranial pressure. So it is a compensatory mechanism. So people at that time thought that probably high blood pressure is beneficial to the patient because it maintains cerebral perfusion pressure. Why? So as not to damage the number. As we know that in the acute ischemic stroke, there are some neurons are infarcted, but there is a zone of neurons that surround this infarction. These cells are viable but ischemic, and this is what we call number. So reduction of the blood pressure in this setting may damage the number. And there are other things, more, not only the blood pressure, that may damage the number. People should take care not to use in the management of acute ischemic stroke, namely IV dextrose. And it has been found that IV dextrose is one of the things that will damage the number. And also hypothermia and hyperthermia, both high temperature and low temperature. These are the things that may damage the number. So please avoid prescribing IV dextrose to patients with ischemic stroke without indication. Only if the patient has hypoglycemia that cannot be corrected by oral route. And in 2015, the Canadian set 220 over 120. Above this number, you can reduce the blood pressure. Below this number, there is no benefit to reduce the blood pressure. The Americans and the Europeans advise to reduce the blood pressure at above this level, but they concluded that there is no evidence if you do not reduce the blood pressure, there is a harm to the patient. What do you think, Dr. Waleed?
All right, Dr. Disugi. Of course, no comment. The issue it is controversial, but all explanation are logic because as you tell and as you mention in yani, details, patient with ischemic stroke, this blood pressure is increased in acute setting as physiologic compensatory response, so as to increase the MAP and to overcome this problem of increased intracranial pressure. If we touch this blood pressure in those patients, especially in acute setting, and we give medications that aggressively lowering the blood pressure without control, this will end with catastrophic complication. And that is exactly what we seen practically in many cases. بيجيبوا لنا ناس بتاعين acute stroke ischemic stroke في أغلب الأحيان بيكونوا بيجيك اليوم الأول بيكون جاي مثلا ب neurologic deficit with hemiparesis. The power is grade 3 plus. بتيجي بكرة الصباح بتلقاه grade 0. بتلقى كل البروبلم إنه one of Harry doctor he started some antihypertensive medication and he used another medication also that increase the blood glucose, disturbs the temperature, and all of these factors should be taken and considered and to be avoided so as to maintain this area of the number alive and to prevent further deterioration and further ischemia. Thank you very much, Dr. Dasuki.
Okay, thank you, Dr. Waleed. Now we have our great teacher, Professor Ahmed Abdullah Ajabador. Professor Ahmed is here, Dr. Waleed, and he is going to contribute in this important topic.
Welcome, our Professor
Okay,
Ahmed Abdullah Ibador.
thank you already so much for this stimulating and comprehensive talk, touching
Thank you.
an important issue, but a controversial issue as well. طبعا regarding the pathology يعني الناس اعتمدوا على البابيلوديما لأنه this is easy to detect at least clinically. لكن the actual pathology is in the wall of blood vessels والهو ده detected clinically easy. لكن the actual pathology is just fibrinoid necrosis as Dr. Dasugi said, in addition to arteriolosclerosis. These are the two main pathologies of hypertension, particularly بنتكلم عن malignant and accelerated hypertension. المشكلة إنه these two pathologies they increase they increase peripheral resistance by hardening the vessel walls. وبالتالي you can think of a vicious circle. The peripheral resistance itself will increase blood pressure and the thing will continue. وهو نفس increase in peripheral resistance هو will lead to cardiac problems like left ventricular hypertrophy and V6. Another effect of these two changes in blood vessels this is going to weaken the blood vessel at the end of the day. They become weaker. And this weakening is the cause of the aneurysms, and the rupture of aneurysm will lead to bleeding, particularly intracranial bleeding. This is from the pathological point of view. أنا دائما أفتكر إنه there is a paradox when نحن في كل الكارديوفاسكولار ميديسين نحن عندنا paradox يعني interest of the blood vessels في كثير من الأحيان بيكون at the expense of the interest of target organs. وبالتالي if you just concentrate on blood pressure and make the blood vessels having normal tension and these things, in most of the cases this will damage the end organs اللي هم actually the actual target. يعني circulation المهمة بتاعتها شنو؟ انه to perfuse organs. وبالتالي any measure that reduce perfusion بيكون على حساب ال end organ target organs. وبالتالي you need to be very meticulous in reaching a compromise between two things. ده الموضوع ما يلي الطرق. لكن أنا عندي هم وافتكره شخصي لأنه المرة اللي فاتت أنا اتكلمت قلت إنه يا وليد لو ده نقول إنه المالجن أو السبيل هايبرتنشن 180 على 120 هتلقى إنه عندك مجتمعات كاملة في السودان ده كلهم هم emergencies. أنا اشتغلت في منطقتين في كادوبري أهلنا النوبة يجوك وحاجة دي يونيفورم very high blood pressure. اشتغلت في مجلس عندنا مجموعة من أهلنا الفلاتة يجوك ببلد بريشر الميزان بيقفل سيستوليك أكثر من 300 diastolic 200 وشوية و they are enjoying a normal life. أنا ده أخلص لأنه إحنا لمتين نظل using this important medicine. لمتين يعني this is an actual issue مش الموضوع ده بس. نحن عندنا our own peculiarities مش في موضوع بس البلد بريشر في مواضيع كثيرة لأنه نحن different people والحاجات دي كلها بتجي نتيجة لأنه we have different environment, different climate, our nutrition is different, our genetic makeup is different. وبالتالي لمتين نحن نقعد نستورد الطب ونستخدم الطب الجايبينه من برا. أنا والله this is a personal headache بالنسبة لي. وأنا بقول إنه نحن كطب في السودان، كلية طب عام خرطوم انشأت عام 1924. This is more than 100 years. أطباء شغالين في كل العالم. They are shaping their medicine in Europe, the UK, Ireland كده. نحن غالبنا إنه to generate a Sudanese type of medicine that depends that uses our own local يعني measures و reference values وكده. نحن different in so many things. يعني مثلا واحد من ال areas in which we are very different هو how we deal with viral infections. يعني الناس تتكلم عن يعني نيوروب، لو الناس اتكلمت عن انفلونزا this is very terrifying them killing. انفلونزا ينفع علينا اي حد. يعني تظن السودان ده قتل بانفلونزا؟ ما في. لو اتكلمنا عن اسبانيك فلو بانديميك واسبانيك فلو اللي هو ديس الانفلونزا 50 million people died in Europe. احنا ما عندنا ولا زول بيموت. This is the same for other يعني ناس كان هيباتيتس بي. البانيك في ده عند الويسترن كوميونيتيز الهيباتيتس بي ما المفروض يكون عندنا، لانه our response is different. لو اتكلمنا عن مجتمعات زي امريكا دايما بيكونوا بيقول لك والله this is for whites, this is for Hispanics, and this is for black Africans، لانه these are two different. اي واحد عامل له حاجات. فنحن نمتين يعني نحن عندنا نحن بنخدم العالم كله. اطبائنا شغالين في الدنيا كلها شيبنج ميديسين في كل العالم. ما المفروض يكون يغلبنا تو شيب ميديسين السودان. انا والله انا 40 سنه شغال في الطب ده، لكن انا تمنيت لو انه ستيل انا بادي تاني عشان ابدا انيشيتيف جديده. We have to have our own Sudanese medicine. We have to stop using this imported western. تكلم عن كنديان بريتش امريكان بتاع، لكن we don't talk about Sudanese. ولو تيجي على الخرطوم ده سير in the continent، ده سير in continent. ما ممكن يا جماعه. حتى الصور اللي بنجيبها دي imported. حتى الزول الناس اللي قدام بيقيسوا له في الضغط ده ليه؟ يعني غالبا نجيب زول السوداني بيقيسوا له ضغط يعني.
Thank you very much, Professor Hamza, our great teacher, for this valuable tips. Dr. Khalid, I think you want to add something? Please welcome.
بسم الله الرحمن الرحيم. الأخ الأصغر الأنيق الراغي وليد حمزة. To start with, I would like to tell you that مقعدك شاغر هنا, and it is high time to come back. Are you hearing me?
Thank you, sir. Yes, I am hearing you, of course, our teacher, Dr. Khalid Al-Talib.
Okay.
And of course, inshallah, as soon as possible,
Yeah.
تلقانا معاك في المنطقة X إن شاء الله.
Yes, we are in a bad mood of you. أول حاجة طبعا, and I attended this lecture before, and for some constraint I came late, لكن I'm dead sure إنه دكتور وليد قتل الموضوع بحثا وأصاب الموضوع. لكن الهايبرتنشن as hypertension is a big issue. ونحن عندنا a lot of malpractice, we have to admit that. طبعا in the new guidelines, hypertension is classified as normal blood pressure, elevated blood pressure, and hypertension. الحتة الفوق الشغل elevated blood pressure انت بتعمل modification of lifestyle وبتعمل measurement of يعني overall cardiovascular risk عشان to start. وطبعا as you know, the diagnosis of hypertension is no longer depends on office blood pressure measurement. في other two ways اللي هو ambulatory blood pressure measurement and home measurement. they should be applied ومهمة جدا وavailable. عندنا واحدة من الحاجات very irritating يا اخوانا قاعدين نشوفه. it is done by our young colleagues. يجي patients ودي اللي بتعمل لنا المشاكل الكومبليكيشن. يجي patients diagnosed for the first time as hypertensive، البلد بريشر بتاعه يكون 190 على 100 something like that، يقول لي خلاص I will not start you on antihypertensive، you just use aspirin. يديه اسبرين و send him home، وبعد ذلك ممكن تحصل مشاكل كثيره جدا جدا. انا افتكر موضوع الهايبرتنشن يا دكتور دسوقي، انا ام شور انك انت مهموم بقضايا الساعه. الهايبرتنشن ده انا في رايي محتاج ل سيريس اوف ليكتشرز، يعني انت بديت بالحاجه الاهم، لكن برضه محتاجين الشباب ديل يعرفوا الحاجات الاساسيه. طبعا now in most of the cases there is no place for single antihypertensive. Combination is a rule. وكل الانتي هايبرتنسيف دراج تعتبر فيرست لاين دراج اكسبت البيتا بلوكر في compelling indication. فالحياة دي المفروض الناس الساعة نحن بنلقى كثير بيشنتس بياخدوا انتي هايبرتنسيف بياخدوا سنجل دراج. This is not good. نشكر دكتور دسوقي انه لمانا اللمة الجميلة دي، ونهنيه على الترقية وهو يستاهلها، وان شاء الله مزيد من التوفيق. ودكتور وليد نهنيك، وان شاء الله نحن في انتظارك. شكرا جزيلا.
شكرا جزيلا دكتور خالد، الله يديك الصحة والعافية.
Thank you very much, Dr. Khalid. We have a very nice lecture done by Professor Tissam Ahmed Ali in the diagnosis and the basics of hypertension, which is available. You can take it. موجودة في اليوتيوب، وإن شاء الله بإذن الله we will have more lectures. دكتور نسيبة، ما سميرة نسيبة. Do you want to add something? Please welcome our dedicated and expert clinical pharmacist, Dr. Nusayba Rajab. And I think she has a lot to add, but our time طبعا is very short, and I am expecting you to have a separate lecture in this in the medications of hypertension, separate lecture إن شاء الله.
Okay, thank you very much, Dr. Waleed Hamza. أنا هتكلم in 1 minute in a summary for this on the management of hypertensive crisis emergencies. دايما treat to goal in timing manner. Dr. Waleed يتكلم in details in the requirements for each comorbidity. Most hypertensive emergencies, the goal is to reduce the MAP or the systolic blood pressure by no more than 25% from the baseline in the first hour. There is some exceptions in case of aortic dissection, in case of stroke, in case of فيوكروموسايتوما. هنا التارجت بيختلف شوية. في الفيوكروموسايتوما to systolic to less than 120 in aortic dissection also in the first hour reduced to lower systolic. But هنا in our setting دايما بيحكمنا ال availability of medication. يعني ما دايما بنلقى انه الفيرست choice هو available عندنا. يعني هنا عندنا تقريبا بس النيتروجليسرين، عندنا لابيتالول and hydralazine. As you know, hydralazine not preferred in any of these comorbidities, just for pregnancy emergencies. فدي برضو ممكن زي كلام البروف انه بيدخلنا في انه نحن محكومين ب international guidelines ونحن عندنا our يعني special setting. Thank you.
Thank you دكتور نسيبة, thank you very much for your talk. زي ما قال أستاذنا بروف أحمد، نحن الجايد لاينز دي بنرجع لها يعني as a matter of academic interest, because this is the only source which is available with evidence what to do. لكن practically أنا أكيد لك تماما، أنا ودكتور الدسوقي ودكتور خالد وبروف أحمد وكل الناس اللي قاعدين معاك دي معظمهم بيعملوا modifications للحاجات دي according للlocal situation و they are taking in a part our special situation of clinical presentation in our local people. أنا الآن بقدم لك في المحاضرة دي والكلام ده كله evidence based from international guidelines. Before just few days before, I manage a case, young man from Somalia. He is about 24 years. He presented with history of acute convulsions associated with severe headache and disturbed conscious level. After I complete my workup, I diagnose the patient as posterior reversible encephalopathy syndrome with complication of hypertensive heart disease and pulmonary hypertension, most likely secondary for this severe hypertension. And it is typical case of hypertensive emergency. I have no intravenous antihypertensive available, only this hydralazine, which I hit it. So I doesn't take this in my plan of the management. I control the blood pressure in this case only by using oral antihypertensive medication. Calcium channel blocker, amlodipine, AC inhibitor ramipril, in addition to beta blocker bisoprolol, and I use little dose of Lasix to control the exertional symptom of hypertension. My patient is lucky he is not inferior and ejection fraction is good at that time. I discharged this patient after 2 weeks of admission. He is alive and well. Pulsion is very well controlled with levetiracetam. Hypertension is well controlled. On discharge, it is 130/70, and everything is well. And even the feature of breast in the MRI, it is totally disappeared in the second image. So this is again will support the evidence of our Professor Ahmed Abdullah Ibador. Why we are not reported this in our reference to make this as official references, to make our guidelines, to make our local protocol, and to take in part our local consideration for this African community. It is totally different from other people, and they have different response and sensitivity to this medication as well. Thank you very much.
Thank you very much, Dr. Waleed, for this very nice lecture. And it is a time to conclude this session. The take-home message to our young colleague: asymptomatic high blood pressure, whatever the number, you don't need to admit the patient. You treat as an outpatient. Early on, this was called hypertensive urgency. What do you call it now, Waleed?
Yes.
Hypertensive urgency has been replaced.
Yes, hypertensive urgency. Yes, hypertensive urgency. In the past, they're using this term. Nowadays, they change this with markedly asymptomatic, markedly elevated blood pressure.
So it is marked elevated blood pressure rather than hypertensive
asymptomatic, markedly elevated blood pressure.
Yes, in the past, people say hypertensive urgency and emergency. The difference between them is the symptoms and the end organ damage, which is found in hypertensive emergency. And in hypertensive urgency, high blood pressure without symptoms and without evidence of any organ damage. So you don't need to admit the patient to the ICU. You can control the blood pressure with the oral medication in asymptomatic high blood pressure. No need to admit to the ICU, no IV medications. High blood pressure without symptoms. Hypertensive urgency, you have to admit the patient to the appropriate place, usually ICU, HDU, and you use IV antihypertensive medications according to the situation. نحن in the acute coronary syndrome دكتور خالد بالذات الشباب اللي قاعدين في ال AR, we need the blood pressure to be high. It's better for us once we decide to go to the cath lab. High blood pressure is very good for us. And if it is high, we can control it in the cath lab with the IV nitrates, because blood pressure, which is low, this is a miserable situation. You don't like to operate on a patient with a very low blood pressure, particularly patient with cardiogenic shock and you need to give any drops, it makes things worse. And such a type of the patients, usually the outcome may not be good. So in acute coronary syndrome, in our departments here, in our settings, please, before you prescribe any hypertensive medication, communicate with us. If you want to go to operate on this patient now, please don't don't lower the blood pressure, because we are going to lower the blood pressure if needed in the cath lab. If the patient is not candidate for urgent cath lab, then you can control the blood pressure according to the guidelines. Thank you very much, Waleed, for this nice session. Thank you very much, our colleagues who are here in the room and who are joining us to the show. And our great teacher, Abdullah Ali. Thank you all, and see you next Sunday, inshallah.
Thank you,
والله
sir.
تكون 12 كده حاجه زي ده.